Good afternoon. My name is Justin Adams, and I am CEO of Digitize.AI, and really looking forward to the conversation this afternoon. I'm lucky enough to be here with one of our partners, Valerie, and one of our clients, Brooke. And so really the intention of this afternoon is to learn a little bit more about the problems we're solving. We really kind of focus on the business case. And if you want to get deep into the kind of technology we're using around AI to solve those problems, we're at booth 41, just straight down there, so we can talk to you more about the technology. But really wanted this to be more of a fireside chat. Before we begin, just curious about the audience. If you're a provider, do you mind raising your hand? Great. Vendors? And everyone else? Awesome. All right, well, without further ado, I'm going to kick it over to Brooke Moore to introduce herself.
Good afternoon. Oh, much better, yes. My name is Brooke Moore, and I am the Chief Financial Officer for the Emory Physician Group Practices. I've been with Emory Healthcare for 28 years, and in this role for 11. Our system is in Atlanta, Georgia. We have 6 hospitals, 1,100 physician MD FTEs, and 700 advanced practice provider FTEs. Our net revenue a year is $3.5 billion, and our physician practices make up about 25% of that. And over the last 5 years, we have grown by 25% in our clinical productivity and volumes. During that same time, though, we have not seen the proportional growth in our shared service areas, which some of you may call overhead or support functions. So while we've grown by 25%, our support services have remained relatively flat. So that brings us to our current state problem, that we are trying to acquire pre-certs for 25% more, and we don't have more people to help us do that. So our first way of solving that problem was we said, well, we have more people we have to acquire pre-certs for. We don't have more people to do it, so just work fewer days out. So we think we're doing well when we touch a pre-cert when it's 14 days before the date of service. That to us is best performer. Well, when you talk to our physicians who are following our request when we say you need to give us enough days to acquire the pre-cert before scheduling the patient. So they schedule 30 days out, but then we wait 2 weeks to touch it, and then we're 48 hours before the patient arrives, and we don't have the pre-cert because we need a peer-to-peer, or we need some clinical documentation. It always comes back to, well, you didn't touch this for 2 weeks. Valid point. So that solution didn't work. So our next solution was, well, we just need to get some temp labor in here to help us. That's very expensive. We found that the work that we need done, it's not extremely challenging work, so it's hard to find people who want to do some of this mundane work. And then the vendor that we're working with is interacting with the physician practice offices just like we are, but they interact in slightly different ways. So we have concerns coming from our providers that why is the vendor telling me this and doing it this way and your internal staff are doing it this way. So we know that's an unsustainable model as well. So that's when I turned to my vendor friend, Valerie Barckhoff, who she can introduce herself in just a second. And I said, we need to do something different. We are not getting where we need to be. So I asked her to work with cardiology because they were the loudest. And I said, just see what we can do differently to try to fix this problem.
Thank you. So as Brooke mentioned, my name is Valerie Barckhoff, and I lead the healthcare advisory practice for a firm out of Atlanta called Windham, Brannon. We've actually been working with Emory for 4 years, but really started working with the clinic about 1.5 years ago. And so when Brooke started bringing up these challenges that we were having with our physicians being very vocal about us not securing the pre-cert, we were having issues where on the same day we were having to tell patients who drove an hour away that we could not serve you that day, we would have to reschedule you, or you might be financially responsible for that. And most of that was due to the fact that we missed some sort of administrative process. I'd love to be able to say, hey, it's the payers that were the reasons that we didn't do it, but in all honesty, it was stuff that we owned. And I always like to focus on the things that we own first before we start going out there and pointing fingers at the payers. So I've been doing revenue cycle consulting for 25 years. So we start with the basic people, process, and technology, right? What I'll tell you is when you're breaking down these different challenges, while we've had advancements in technology, meaning Epic and things like that, we really haven't seen this earth-shattering change in the technology we have. So we look at how does the technology work, we look at how our processes are built around that technology, and then we work around the people. Do we have enough people? Do we have them trained appropriately? And so we really started going, this is a very complicated problem. We have 2,000 people we're trying to get pre-certs for. You know, a $3.5 billion organization. We have approximately 80 people across the entity that we're trying to do this for. And the CFO of all of Emory Healthcare, I tell Brooke this all the time, he's got a wonderful Georgia accent, but I hear him going, Valerie, you got 550 FTEs, make it work. And I'm like, all right, I am not going to be able to add more FTEs. I can only adapt my technology to a certain extent. And the providers are having their set of rules that are constantly in change, and they reside in the brains of my pre-cert staff sitting in downtown Decatur, Georgia. And so when I was challenged with, you've got 550 FTEs, make this work, I started becoming intrigued with what Digitize was doing. So we started meeting late summer, early fall of 2017. And they brought to the table data scientists and people who are machine learning experts. And we started going through the different challenges that we have in the revenue cycle and really focusing on those things that are predictable and repeatable. And I said, one of our biggest issues that we're having, that I know every single provider in the country is having, is the ability to obtain pre-certs. The rules are constantly in change. We do not have enough staff to do it. And it is a huge dissatisfier not only for our physicians, but for our patients. So we asked Digitize to come out and spend some time observing the processes to see if they agreed with this idea that it is predictable and it is repetitive. And so I'm going to turn it back over to you, Justin, but we really do think there's a huge amount of efficiencies that you guys are going to be able to bring to the table.
Thank you, Brooke and Valerie. So a little bit about my background. I may not be a likely candidate to have started an AI healthcare company, given that I have zero healthcare background. I do have a lot of automation and AI background. I actually started PwC's Center of Automation about 6 years ago, and got into this world through that route and grew it over a number of years. And then had a personal experience where I had my 6-year-old son visit the ER. And while he was fine, the billing was atrocious. My wife's getting sent to collections on bills we'd already paid. And I said, something's broken here, I need to investigate. And that led me to the world revenue cycle, which I had frankly never heard of. And so once I started investigating, I saw, oh my gosh, there's quite an opportunity here to fix this broken system, using this technology that I was familiar with. And so I think really one of the reasons we were able to see the opportunity was not having that healthcare background, not thinking the same way a lot of people who've grown up in the system think, and so we're really able to come at it with a new perspective and some new thoughts around it. So maybe we could spend a few minutes talking about some of the things we're working on right now, and then get into more future state vision. Whoever wants to.
Yeah. So what we've done right now is we've been working pretty much since, I think, the November timeframe to really break down what is predictable and repeatable. So when I talked about the fact that as a traditional consultant we look at people, process, and technology, there's been nothing earth-shattering in the past 25 years. And to me, this is one of the most significant changes that we'll be able to bring in as a tool to become more efficient. So we've partnered together. We're really breaking down those processes. And the tool, I keep telling everybody at Emory, it really is a digital employee. This is not screen scraping technology. This is not a workflow tool. This is truly a digital employee who's going to work 24/7 a day. And what she's going to do is she's going to be initiating all of those pre-certs. So when I talk about repeatable and mundane tasks, what my people or your people are doing is they go out every day and they get this work queue. and they go out into our HIS system and they look for the clinical documentation. Then they toggle over into a portal and they upload and they kick off a pre-cert. Now, we're working 8 to 5, just like everybody else, but we have a lot of times where patients are added on at the end of the day. We have a lot of missed opportunities because of the way the workflows work. The patients will drop off before we ever get a chance to see them. And so the idea of having a digital employee who's now going to initiate those pre-certs for me so that I can have my staff doing the more important functions. And the more important functions are going to be those conversations that require human interaction. Because we've been so busy doing the repeatable and mundane tasks, and the predictable tasks, we don't get to have those conversations with the payers justifying the reason for your visit. That's what our staff really needs to be doing. But we've been so focused on teeing up and initiating those pre-certs, we don't get an opportunity to have those phone calls and say, this is clinically justified, this is what the documentation is saying. So we're going to, upskill our staff once Leah is live, and then we're going to be able to have them focused on those human interactions that we cannot automate. And we really are excited about the opportunity that it brings. So, do you want to? Okay.
Yes. So, Brooke, I'm going to ask you a question. If you look, let's say 2 years from now, and you look back on this whole experience, what would you consider a success? This was success. Leah was successful if.
So Leah will be successful to me if we have no more temp labor helping us procure our pre-certs, because that's just extra cost. If we are not limited by the number of transactions that we can touch, but we're limited by the clinical documentation that's complete. So I would love it if we're saying, well, we're only working out as far as your documentation is done to let us submit the pre-cert. And I think the third thing is we would have a very collaborative relationship between our centralized pre-cert function, the people who work in each of our physician practice sites, and the physicians. With our current workflow, we work them centrally up until 72 hours before the patient arrives. Then we start firing off emails to the sections to let them know that we haven't yet procured that pre-cert number. And then we send another email if it's 48 hours. And then we send another email if it's 24. And when it reaches 24, I'm telling y'all, this is our process. I'm not saying it's best practice, but this is what we do. So when it reaches 24 hours, then it's up to the section to get the pre-cert. So the section has, the people who work in the section have the closest relationship with the physician. So their perception is we don't work it because they see it was scheduled 35 days out. We didn't touch it until day 14, and now we're turning it over to them. So they think we're just not touching it so that they will have to do the work. Well, so then you get within 24 hours, and you're having to make the decision, do we tell the patient to stay in South Georgia? Does the patient come up and we do the treatment anyway? And it just turns into a battle. And there's always finger pointing. So to me, a success would be the group is working together as a team, and it's not finger pointing. But the way the process works now and how long things take, to what Valerie was saying, first you have to initiate the pre-cert. With some payers, when they respond to you to tell you, okay, you were given a pre-cert, the way they respond to you is they post it out on their web portal. So you don't know if they gave you a authorization or not until you go out and look at their web portal again. So when we're in these 72-hour windows, we're not even really working new pre-certs. We just keep going out and looking to see has anything been posted. So one of the things I'm really excited about with Leah is ideally, we leave at the end of the day. She sends off all that initiation. She can still then go out and screen scrape to see when authorizations were posted on the web portal. And our team is working the things that are still manual, where you have to make phone calls and you're not able to work with the portal, or things that were problems. And then we're working more collaboratively with the section in advance of the treatment as opposed to within 24 hours of it.
I was going to add on one real quick thing. Do you want to? Okay. So I was going to add on, in addition to Brooke's definition of success, I really think having absolutely no failures because of an administrative issue would be the biggest win we've ever had. Now, the data suggests out there we're always going to have a 10% denial rate from the payers because of the benefit plans that the patients have with their managed care company. But for us to be able to have 100% that's in our control done, and to be able to notify patients earlier when there is a benefit issue. Sometimes we're notifying them when they're sitting there getting ready for their procedure. We will know that earlier with Leah, and we'll be able to communicate with the patient, with the doctor, with the section to let them know what's going on. So to me, that would be the definition of success too.
Great, thank you. So just a quick overview of, you may have heard Leah. So what is Leah? Leah is a system of intelligence that we built. Basically, no, she's not, and she's not. No. But yeah, so we developed the system of intelligence and actually have a patent on it. It basically combines bot technology with AI applications. So it's a thing that we get efficiencies right out of the box with, and it gets even more efficient over time. And don't hold me to it, Brooke, but early signs are showing about a 500 to 600% ROI. So pretty compelling value prop. Not to mention the downstream effect of less peer-to-peers with the clinicians, and frankly, taking the stuff off the plate that people don't want to be doing anyways, right? So we have time. We have 2 more minutes, and Valerie, I wanted to ask you, as you kind of think about the future of technology and where this is going, and just the revenue cycle in general, where do you think we're going to be 2, 3, 4 years from now with AI and kind of the applications?
So I'm super geeky excited over everything that Justin and Digitize are doing because I think it's going to completely transform the revenue cycle. I do think you're going to see a lot of what we do can be done by a digital employee. What we do in terms of account follow-up, a lot of what we do in appealing denials, we can automate. I mean, a lot of what we do has been that repeatable, predictable stuff that we've relied on very low-waged employees to do. I mean, I think it's a shock to a lot of people outside of the healthcare industry who we compete with when we're hiring employees and the complex things that we're asking them to do. So I think as we transition to having more digital employees across all aspects of the revenue cycle, we'll be able to probably see a smaller revenue cycle in terms of FTEs, but a higher skilled labor who's able to handle those more complicated tasks. And at the end of the day, you're going to see improved net revenue because we're going to have less missed opportunities. So I really do think this is the one thing over the next 2 to 5 years that's going to really transform revenue cycle leaders, operations who decide to take advantage of that.
Well, thank you very much, everyone, and we'll be on the side for questions and answers and our booth for the rest of this week. So thank you very much.